I am so happy you've joined us. We have a whole team here from the health department and the Vermont Child Health Improvement Program. We're also thrilled to have our health commissioner, Mark Levine, with us. Next slide. We're going to kick us off by making sure that we all come together today in the spirit of every single one of you is part of the Perinatal Quality Collaborative in this great state of Vermont. What we mean by that is that we're all working together in different spaces and in the same mission, which is we're trying to optimize care and the health outcomes in pregnancy and infancy. And we do that by working together. And we also do that because we're VCHIP using a quality improvement framework. So what we do all together, and many of you are part of this, is we set the priorities together with the health department, because the health department, it has all the data and understands what needs attention. We also do a lot of outreach and education as it relates to the relationship between some of the content experts up at UVM and their delivery of healthcare and all of our hospitals that are in the same pursuit. We love the quality improvement aspect of it. And then we circle back and we monitor again and wonder what else needs attention. So welcome to the PQC Vermont. Next slide. I hope by now we all know how to do Zoom, but microphones are best muted until you're ready to speak. We do want you to know about the show captions feature, which is in your navigation bar, which will automate the audio for you for captioning. And then please, 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 at the very end, we are a quality improvement entity and we need to know how this went. And the evaluation matters a lot to us. So there'll be a QR code at 12:59. Do not depart. Thank you. Next slide. Okay, this is our ambitious agenda. We've welcomed you. We're going to talk about this long dreamed of initiative to improve the quality of our birth certificate variables. We're going to talk about which 11 variables we picked and why. And then we're really going to turn back and thank you for the input you've already given us about your individual hospitals and how you do your process for birth certificate data. We're going to talk about the ongoing work to get some baseline, and then we're going to set up how we're going to come alongside you and provide tools and training, as well as set up the year for you in terms of dates, expectations, and still leave time for questions. Next slide. So here's your team, and I'm just going to have people wave, and if people aren't on camera, it's okay, but our names are here. So they're calling me the faculty lead. I think it's because I spent 11 years at the health department, and I care deeply about the integration of public health and data into clinical care. Elisa, who is here with us somewhere, I think, big Zoom, is our family and child health director. Katie, give a little wave. She's going to be delivering some slides in a minute. She's our perinatal nurse coordinator at the health department. Cindy Hooley, vital stats information manager, such a key long-standing role for the great work we do. Peggy Brasigovic is on camera. Thank you, Peggy. She's our research and statistics chief. We've got Julie Parent. All roads lead to Julie Parent. If you haven't figured that out yet, she's our project director, perinatal QI coach at VCHIP, and also all roads lead to Angela Zinno, our project coordinator, who keeps the trains running. And look at how there's just this little outline of 7 women with side parts and cute little shoulder length hair at the bottom of the slide. Next slide. Great team. But really, this is nothing without you. And boy, do we love our community hospitals. I said hello to Kate at the onset because I am a pediatrician, but I was at Porter Hospital for a long time, and I sure do know what it's like to be out there in the world away from the academic medical center. And the work that goes on at these hospitals is so important to the health of pregnant people and children. And we really need all of you. Most of you have engaged, and some we're still working on the teaming, and we're just here today to say we promise it'll be fun, and you would be welcomed into this collaboration. Next slide. Okay, I have the great pleasure of introducing Dr. Mark Levine. It would be shocking to me if folks didn't know, because this great leader took us through the most significant public health crisis of our time, hopefully of a century. What's so fun about Dr. Levine is I actually knew him before. Oops. I knew him before the crisis, and I knew him before he was a health commissioner. So he joined the health department in 2017. Wow, we're going to have a 10-year anniversary soon. So Dr. Levine believes deeply in what we call this nexus of clinical care, education, public health, advocacy. And what he's really seeking to do is improve the health of populations through policy and cultures of health, which is why we're so happy he's here today to spend a few minutes talking to you about why this matters and why we're so grateful you're engaging with us. Dr. Levine.
Thank you so much, Brina. Yes, I'm going to engage with you in hopefully acceptable ways, but maybe provocative ways as well. So I'm supposed to be giving you some inspirational comments on this kickoff call about why is birth certificate accuracy through data entry so important. And as you know, you're going to go through a lot of sessions that have all kinds of other nice titles to them, all with this quality improvement initiative in mind. So I'm going to set the table a little, highlight the importance of the topic and why you should pay attention. This is really more than what it's labeled, a birth certificate initiative, because it's really a parent and facility worksheet initiative in a broader sense. More on that to come. I'm going to discuss those forms, and I want to provide a little discussion on VCHIP and PQC Vermont to provide the context for this initiative, and conclude by giving you a perspective on the higher significance of why you're here. But first, I did do a little research on birth certificates themselves and discovered some fascinating information. Now, as you know, vital records in Vermont include births, deaths, marriages, civil unions, divorces, dissolutions, fetal deaths, abortions. And statutes in 2019 enhanced safety and security, trying to protect against misuse and identity theft and who can access a birth certificate, which of course is a vital record that documents the birth of a person. Didn't realize that because we live in this country, there can be multiple ways of actually documenting just that event, depending on what jurisdiction you happen to be in. It's the responsibility of the healthcare system to see that birth is properly registered with the appropriate government agency. The UN says every child has a right to a name and a nationality. And formal recognition of one's existence is essential to accessing so many rights, proving age, nationality, receiving healthcare, going to school, participating in sports, being adopted, getting a passport or a marriage license, voting. Birth in the US confers citizenship by birth, so certificate doubly serves as evidence of this. And it's required to be filled within 5 days by a physician or midwife. Now, to me, the National Center for Health Statistics has some data requirements, which are pretty straightforward about the child and the parent in terms of names, days of birth, addresses, health information, prenatal care received by the mother, type of birth. But much more intrigue comes from looking at some of the controversial aspects of these seemingly simple documents. If you look at our history in this country, birth certificates, unfortunately, have been used in the wrong way at times, enforcing racist segregation, policies of white supremacy, erasure of indigenous people, allotment of indigenous lands, adoption laws, enforcing gender identity or transgender rights, which of course Vermont's recent legislation stands out in a positive way amidst a sea of negativity on this issue. So while this seemingly simple document may not superficially look like it needs QI efforts, its potential for misuse should remain a perennial point of discussion. Now, in broadening this discussion to public and population health, it's great that VCHIP is running the show here. It's because VCHIP is a population-based child and family health services research and quality improvement program at UVM that, as Brina herself epitomizes, works closely with public health, as well as the entire clinical sector and multiple other partners, all in an effort to optimize the health of Vermont's children and families. So what is PQC Vermont? Well, you saw one quick slide. There's actually a national network called NNPQC, which has a mission of supporting the development and enhancing the ability of state perinatal quality collaboratives to make measurable improvements in statewide maternal and infant health care and health outcomes. They're basically multidisciplinary teams working to improve these outcomes using evidence-informed practices and processes like QI principles to address gaps in care. And there are 5 areas of focus on the national level, which should resonate with everyone: reduce preterm births, reduce pregnancy complications associated with hypertension and hemorrhage, improve identification of and care for infants with neonatal abstinence syndrome, reduce racial and ethnic and geographic disparities, and 5th, reduce cesareans among low-risk pregnant women. So PQC Vermont is obviously a formal partnership of longstanding VCHIP projects that have joined forces to become Vermont's resource for perinatal care. In partnership with the Department of Health, Family and Child Health Division and Health Statistics and Informatics Division. And it's really trying to mobilize state networks to implement quality improvement efforts and improve care for mothers, babies, and families. By setting perinatal outcome priorities, providing outreach and education, advancing QI efforts like the one you're involved in here, and monitoring healthcare outcomes. Now let's get down to the work at hand on the worksheets. I am not an OBGYN, so I never had to participate in any of these forms. But the parent worksheet on the child's birth certificate includes things like the mother's marital status, education, race, ethnicity, smoking status, WIC status. Father, really, education, race, ethnicity. And then the facility's responsibilities involve newborn statistical information, going from the APGARs to the birth weight to what kind of gestation, is the baby breastfed at discharge, etc. Information from a statistical standpoint on the mother. Was there a need for transfer? What's the prior OB history? Did they have prenatal care visits and when did they start? And then medical and health information, which has a whole host of things that I'm sure you'll hear more about. Go from pregnancy risk factors to labor to infections during pregnancy, group B, etc. Now, I don't have all the data on how successful all of this is actually reported, but I think the fact that you're in a quality and performance improvement initiative should tell you something. And improving the consistency of data collection and reporting, reliability, accuracy, and adherence to a defined standard is what quality improvement is all about. There's a few tidbits I picked out about giving birth in Vermont or New Hampshire in 2021. Out of 5,000 plus live births, 13.8% of them occurred in New Hampshire. 3.3 out of every 100 live births occurred out of the hospital. I thought that was low. I thought it would be higher, actually. 38% used Medicaid as the primary payer for delivery services. 28% were enrolled in WIC during pregnancy. And almost 90% of infants were breastfed upon discharge. I don't know how many states can say that. Congratulations. Now, some truths and 5 pivotal points to make regarding the kind of data that these examples illustrate and why this data is so essential to public health and the people we serve. First, birth certificate data is the foundation of public health decisions about improving maternal infant health. Where and how else would we get the kind of information I detailed that is present on these certificates and forms? And how could we develop policies and practices if we didn't have proper characterization of problems through a comprehensive and accurate data set to provide a data-driven approach? Surveillance, of course, is critical to public health. It's one of its core responsibilities, whether we're in the problem formulating phase or the health outcomes review. Second, we use birth certificate data to improve care for pregnant people, birthing parents, and babies. And I will beg forgiveness for this being the first time I used the term pregnant people, because so much of what we actually are talking about in these forms and everything actually is not as advanced as the words pregnant people. It continues to use the word pregnant women or mothers or what have you. But anyways, it is important to know things like the timely involvement in prenatal care, maternal health factors impacting a pregnancy, the frequency with which prematurity exists, the need for transfer to higher levels of care, delivery issues, is the parent poised to be prepared and successful for breastfeeding, and then pair the data with evidence-based solutions. Understanding where the critical partnerships are between the healthcare system and state health programs and community-based organizations. There's a lot of work our health statistics division does with the data. Everybody knows PRAMS, the Pregnancy Risk Assessment Monitoring System. They use that where birth certificate data are used for sampling. We monitor key indicators for birth certificates to assess trends over time. Third, monitor population health. I'm so grateful that Vermont does not share in the heart-rendering maternal and infant mortality statistics so many of our states are confronted with, notably many in the South. But having mortality and morbidity data and being able to examine these from a racial and SES equity position is critical to practicing public and population health. And we all know the important linkages between these statistics and the health-related social needs of many in our population when it comes to access to wealth, housing and food security, transportation opportunities, access to services, access to quality health care. Fourth, solve public health problems at the local, state, and federal levels. Clearly, we look at a lot of our data from a geographic equity position as well. And in Vermont, the importance of rurality is ever present. It can play a role in prevention efforts, resource allocation, programmatic initiatives to address the whole continuum of equity-related factors, not to mention access to healthcare and quality of care that is available on a local or regional basis. And finally, making wise decisions about where to spend limited dollars, helping public health, the healthcare system, policymakers, and political leaders make the often very tough decisions and to be strategic and prioritize how to move health outcomes in a positive direction. So I hope your work in this learning series will enable us to move forward in all of these lofty goals and help accomplish many of VCHIP's and PQC Vermont's significant goals that they have for their overall work, as well as this particular quality improvement initiative. Thanks for allowing me to provide the initial comments.
Thank you so much, Dr. Levine. Wow. I'm glad we recorded that. So there it is. I'm going to ask Angela to put the slides back up for us. You're welcome to stay, or you probably have other things to do, but we're so grateful you came. And we're looking forward to having you at more PQC events. Thanks for understanding us. Katie Leffel, up you go. Next slide.
Okay, all right. So thank you, Dr. Levine. And this is just a little bit about our birth certificate data. So we collected more than 100 pieces of information on our birthing people and babies. And birth certificate staff are on the front line in ensuring this accuracy. And you're such a vital part of the healthcare team. And I've got to meet some of you, and Julie and Angela have met a lot more of you, and all your sometimes you're in other buildings or other floors, but you're all really, really vital with this information. And then Dr. Levine indicated some of the uses, but it's used not only locally and state, but also by our national partners. So it's really important, this accurate information. And it's a consistent source of health information on all Vermont babies and new mothers and birthing people. And also it impacts your own hospital performance records and adherence to best practices in perinatal care. So it impacts the way that your hospital shows up as well. So next slide. Okay, so this is talking a little bit about how we use it with the Perinatal Quality Collaborative. So you're seeing two different reports that we produce. I'm saying we, it's really the PQC and VCHIP, but I help participate a little bit when I'm going to use we. So anyways, there's the first one is for the community hospitals. They do a huge amount of work to produce this report and then present it to the community hospitals. Many of you have been, I'm sure, a part of that. There's a lot of discussion about the data and the accuracy of the data and all those pieces because it's so important for representing your own hospital's performance. And then last year we had the first perinatal public health report, which is a report that we produced that's a little bit more, it's the public facing and public health versions of it. So it's not so much all just only the clinical and sort of the data that we produce for the community hospitals, but this is also something that the communities can use and see sort of where they are as far as data with contrasting with other regions as well. So next slide, please. And this is talking a little bit about how we use the birth certificate data with internally for the Department of Health and the Family and Child Health Division. So we use it a lot for finding and applying for grant opportunities. For instance, so we've got this enhancing reviews and surveillance to eliminate maternal mortality, which is a big CDC grant that is funding a lot of our work around reviewing and addressing perinatal death in Vermont. So any death in the pregnancy or full year postpartum. And then we also use it for the WIC program, the Women, Infants, and Children Supplemental Nutrition Program, the Perinatal Quality Collaborative Capacity Building Grant. So that's a grant that's funding a lot of the work for we're talking about today and a lot of other projects as well. We also have a grant we applied for, Maternal Health Innovations, which is another big grant we're finding out this summer. We just also have another grant that was around maternal mental health and perinatal mental health. So it funds a lot of grant opportunities for us here in the state. All right, next slide. So this is talking a little bit about some of the things that we've learned from our visits with you, which have been so fun. So we have learned that, not surprisingly, data entry processes vary quite considerably from facility to facility. So we're seeing lots of different processes and learning some best practices already around what really has worked well for some hospitals. The quality assurance and audit process, again, varies at each facility. So that's learning, again, a lot of the variations that are working or not, maybe not working as well. Some facilities have modified the parent and facility worksheets to meet the needs of the hospital and your data entry processes. So a little bit of variation there, which has been really interesting. And then the challenges with completing the data entry, because sometimes you're looking through the EMR or the EHR and you're not finding what you're looking for, or it's located in different places. Sometimes it's not integrated well and you have to do a lot of digging. Different people have different accesses. We're finding a lot of So issues like that as well. And then also just some questions sometimes that come up around the actual wording on the forums and what they mean, and on the parent forums and things like that as well. And I believe this may be my last, no, it's not my last slide. Never mind. Next slide. All right, so this is just some photos of our experiences with coming to visit you guys all at your facilities. And you'll see our process there with the sticky notes and the big post-it pages, and lots and lots and lots of pens and office supplies out on the table to try to get an idea of your workflows at every different hospital. And you guys were really generous with your time to come and meet with us and take the time. And like it says here, we had all sorts of different people coming, health information management, OB, pediatrics, certified nurse midwives, nurses, nursing assistants. Like you all really came forward to help represent your facilities and help us collect this information. And then next slide. Feedback. So I referenced a little bit about this already, but recommending updated language on the parent facility worksheets. Some of that we can do on our own, and sometimes it takes some okay from higher up national folks as well. But we're definitely passing the feedback on from you guys. And enhanced communication between clinical and health information management staff. So not surprisingly, sometimes, like we talked about, there's sometimes even separated far away in space, but also in role. So sometimes we just need to help make those connections a little tighter, or tell like this facility is just it this way, maybe this will work for your facility. So we're kind of doing that work. Definitely need to provide training and educational opportunities for your teams to clarify definitions and medical terminology that's been identified many facilities, and we haven't done a statewide training on birth certificate data in a very long time. So we need to do that. And just like raising up that awareness around the overall appreciation of the role of the birth certificate health information staff, hugely important. And again, often doesn't receive necessarily that training or support that they might need, and we need to do a better job at the state with that. So providing additional information tools. So a reference guide for you all, best tips, best practice learned from different facilities, and sharing that information with you around in the informative pieces. So next slide, I think I pass it off now.
Thanks, Katie. I did want to give Peggy space for a sec if she wants. There are a couple other ways that the health department uses this important data that we wanted to highlight for you. Peggy, did you want to tell your favorite ways? Yes.
Yes. I'm Peggy Brzeziewicz, and I'm with the Division of Statistics and Informatics. So the birth file is one of the most used in health statistics. And Dr. Levine has referenced our PRAMS project, which is the survey of women who recently gave birth. And we use the birth file not only to select the women for our sample, but the addresses for those first contacts. Then, because the two files are linked, we're able to skip asking mothers some questions such as, their marital status or their education, or questions about the infant such as birth weight or weeks gestation, because we include that information from the birth file in our analytic file, and then we have it for our analyses. And this is a CDC funded program, and the research file is used not just by Vermont, the Vermont PRAMS program, but there's an all-site database that's made available to researchers. Other uses include Vital Records produces a weekly report on new births that have been entered into the birth file, and they send that information to the newborn screening program so that they can make sure that there's no babies that have been missed. My team produces surveillance reports, both for all resident births, but then again, a second report for just those records where WIC is indicated, and that is made available then to the WIC program. We maintain a much larger spreadsheet with just all sorts of variables from the birth certificate. As again, Dr. Levine had referenced, we're monitoring those all the time for trends and for discontinuities. I also want to mention that NCHS, which you'll hear a lot about, and you'll see on your guides, makes a research file available nationally. And so that's used by researchers. It's used, for example, by the March of Dimes to produce their perinatal report, which includes data on every state and then makes comparisons across the state, across these measures, to the national data. So thank you, and I will turn it back to Brina.
Thanks, Peggy. So there's your why. That I'm learning a lot today. This is great. I did want to acknowledge in the chat too that our friend Jade, hi Jade. Jade reminds us too that our midwives also do the births. They actually do the worksheets and fill out in about 2% of the births. An added awesome member of this great team. Okay, so here we go. So the reason we've done the why, we've gotten us all into this important shared space that this data matters. This is not data that gets collected and goes onto some shelf and gets all dusty. This is real time, super important data. So like all good data, it has an opportunity to improve in terms of its accuracy. So the way we're going to do this quality improvement project is we've learned from many states that are a little bit ahead of us on this, that it helps to pick a handful of indicators that you can really use as your process to understand how data gets collected and sent to the health department and then comes back. Or is communicated with. And then that process would then help inform the whole set of indicators. This was not trying to pit indicators against each other or us having any, deep attachment to these 11 that we picked, but we did have a process ourselves with our health department colleagues thinking about relevance, and we'll talk about that in a second. So we want to make sure to improve the accuracy of these 11 as a way to improve the whole darn thing. But we also want to learn and share with each other about what you're doing, because we've already learned from these hospital site visits that you guys have worked out some stuff that VCHIP loves to take someone else's hard work and give it to the other hospitals that haven't done that yet. And we call it, Angela has to help me, stealing shamelessly. And there's some funny term we use. And then we want to then learn from each other, become a resource for you to share all the great tools you're using. And then we want to continue to have an educational process where as you have new people come on and staff changes, and there's this ongoing observation that the quality of the birth certificate data matters to this huge team of people. So you've become extremely important in the world, but you already were. But as we turn more attention to this, we're getting even more interested in your collaborative process in your hospital. Next slide. So, sorry for the small font. Quality improvement people love a key driver diagram. The only thing this is for us to organize ourselves around an idea that we're all moving toward the same aim, which is that in 9 months, we want to improve the accuracy of those 11 indicators. Pretty simple. And we've shared today the why. We want to do it to support public health, but also to, ultimately improve outcomes for Vermont's pregnant people and children. So we're going to do that by making sure we all understand the importance of the data, which is great because that's why we're here today. We're just kicking off the shared learning. What is this data and why is it so important to Dr. Levine and everyone else? Strong communication between teams and data people, the clinical teams and the data folks. I love Vermont so much. Sometimes you might be related. Sometimes your cousin is the data person, the health information manager, and you're the nurse manager. Sometimes you've never met. And we said that at the beginning, but we're going to say it a few more times because this project is at its roots relational. This is about you guys hanging out with each other and having a shared mission. So we want to do some ongoing training on what we mean by the indicators. What is the specific definition? We have a lot of people who at the health department in particular who really know what they mean. And then we know that sometimes at the hospital level, it gets a little like, wait, I don't know how to find that in the chart, or I need some help. And that's why we've created this whole team for you that already existed, but we're putting us in the forefront. And then we want to do what I just said before, is just identify best practice and keep spreading it, because we learned so much from you. And so on the right side, I'm not going to show you that, but it's too small. But within each of those drivers, we have a bit of a plan, and they all interrelate. But this is kicking off today to say that these drivers are going to be our work together in learning sessions in the future, the next of which will be in September. We're going to give a little break in the summer to get the data right. Next slide. Okay, so what do we expect will happen and know to be true? So we're going to do at least 3 more virtual learning sessions with all of you to kind of dig in deeper to some of those key drivers and to talk more with each other. It won't be so much of this like you eat lunch and we talk. It'll be more sort of learning together about how to improve our efforts. And then we are going to provide, this is a nice QI strategy, to have an office hour set up where you're welcome to pop on, no obligation, but it's your place to get questions answered on the first Wednesday of every month from 1 to 2. And that it'll probably become more clear to you what your questions are when you start diving in a bit, and we'll all be there for you. Next slide. Okay, this thing's all about teams, and it's all about relationships. So we need a clinical lead, and we need a birth certificate health information manager, which we shorten to HIM. I do not prefer that, but it's so funny because we only know each other's acronyms after we learn them. So that's new for me. But in that space, I think you've probably already done this, but we need at least 1 clinical lead and 1 person from the information management side. And that way, the 2 lead designees will need to know the reliable data sources for those 11 key indicators. And so you might be the ones that want to pop on those office hours and say, gosh, with the breastfeeding one, we don't know exactly what this means and we need some help. And obviously we want the leads to have gain more knowledge, but have some baseline engagement in perinatal and newborn health. Next slide. And then we want to make sure that that clinical lead can communicate with the rest of the clinical team. And so when I think about one model that usually works in this space, all roads lead to nurse managers, right, in community hospitals. And in that nurse manager role, making sure that everybody knows, and it's nice to see some of our other clinical colleagues on as well, because we really don't intend for this to be just 2 people in pursuit of this big shift. So as strong and as often the communication can be, and because it's virtual learning series and sessions, we'd love as many people as possible to come on and just actively or passively listen to get into this quality improvement space of this important project. And then within the birth certificate health information manager lead, there's also another group of people that you might want to organize and encourage, and not personal, but personnel who complete the birth certificate. So if you obviously have the luxury or the gift of a nice team, and it goes way beyond you, the team would really want to participate and listen in and learn as well. Next slide. Okay, but here's the real deal. We know that you are completely inundated with quality improvement and data collection and pressure. And that's the commitment of this team, is to not come in some space of, that we've been designing this on some whiteboard and we've never delivered healthcare and we don't have any idea what happens in hospitals. That is completely false. We are so aware that you have a long list of things that has to be accomplished in service of so many partners. You've got regulatory people, you've got hospital initiatives, you've got local decisions, and then you have VCHIP. And so in that space, we really want to identify as the group that is open to that feedback, shows up in service of you as a scaffold. We're not handing you this and saying good luck to you. And so that space you will always enter with us. Data, data, data. And it is getting a little ridiculous out there. However, this project is at sort of this baseline root of quality that will really inform that whole vast array of things we outlined before. That's not to say other data collection things aren't helpful or important. I'm not pitting it against each other. I just really wanted you to know we have a commitment to keeping this low burden, but we still need a level of engagement to achieve our goal. It's like a nice little balance. And we want the feedback that this is too hard, or that something isn't understandable, or that you're really bogged down, because that's exactly how we learn how to come in. And this is not like a one and done. We're going to be working in the space for a while, because we are so committed to sort of resetting this team that comes together around this really important vital record. Next slide. Okay, almost done, we promise. So we do organize ourselves around a true approach. We are not winging this. So we are currently in phase 1, which is the baseline data collection. And we are happy to report we have done that data collection in 2 of your hospitals. And that's really not on you. That we had a wonderful 4th-year medical student who did that with us. And like all good 4th-year medical students, they depart. They have departed. So we have found another one, maybe not a medical student. We have found another human that would like to continue to engage for the rest of your hospitals to just figure out, what are we finding in the chart? What do we know from vital records to sort of set the table that we have this discrepancy, which, by the way, we do, so that this quantifies the discrepancy. So those of you that are, and there's a little bit of a process to get this person access to your record so they can do the pre-work, the baseline data collection. So we really need your help, because sometimes this gets bogged down in with people that don't know what we're trying to do, like the protectors of data, and we have all of that worked out in a way that we could show you if your hospital isn't clear that this would be a good idea. So that's my short way of saying most of you are just waiting for us, this nice new person that we hired, but a few hospitals are sort of wondering, and any effort in the space of baseline data collection would be great, because if we can get that done, we'll know what the what is, because we do have to quantify how much we're seeking to improve. And then when the intervention of you learning and everybody working together on these 11 indicators is over, we will go back and we'll do that same chart review again to show the improvement. And the cool part about a QI project like this, we're not seeking like some mega thing. We're showing that with this level of intention and teaming, we're able to go boop, boop. So that's very important to us. And then we also really want to do some maintenance data collection, because everything about quality improvement is making sure that a system changed and that a process changed so that the change is sustained. Because wouldn't it just be so terrible if we worked so hard in a space and then the minute we stepped away, it went right back? It's like spring, spring. So come along with us to the 3 phases. Next slide. Okay, so I know you've been waiting this whole call for these 11 indicators. Here they are. So please forgive the right hand. We really want a reason and a rationale, but we're recognizing that calling something clinically relevant as opposed to public health relevance is a binary that's not really the way our brains work. But we called it out just to really explain that our public health colleagues have noticed for years some things that might not be explained in a way that are collected properly. And also we've just seen some discrepancies. And so this is how we want to talk about this today, but it was really a team of clinical folks and public health folks that decided on these 11 things. Pre-pregnancy hypertension, gestational hypertension, preeclampsia, pre-pregnancy diabetes, gestational diabetes, and you can see the complexities here already. How on earth are you supposed to know what happened pre-pregnant? Well, we are hopeful that health systems communicate with each other. But one of the QI things that we're really interested in is when that doesn't happen. When a primary care situation where a person is known to have hypertension, then that person enters the pregnancy space, how does the obstetrical provider know that? Sounds so silly, but it is glitchy out there. So that pre-pregnancy piece matters. Gestational diabetes matters. Breastfeeding, there's lots of places to find out about a person's intention to breastfeed and whether then they did breastfeed, and finding it in the chart and also entering it needs some QI. Assisted ventilation, here come the peds ones, assisted ventilation after delivery, and whether that baby was transported and received a NICU admission. Hard to get that data sometimes because the patients left your shop, and it matters. So the accuracy of that is on our list. Obviously, premature rupture of membranes, and we're very interested in payer. So how on earth are we supposed to prioritize where and when we need health policy change around insurance if we don't know if there are disparities among our pregnant people for the type of payer? And that's also should be simple, but not always in the part of the chart that we're looking at. And I'm old enough to remember the search because it was paper, but trying to figure out if someone's birth is covered in the Medicaid program is needs attention. Induction of labor, super important. And then here's a little quality improvement term we don't really need you to learn, but we need to do, which is called a balancing measure. When you're looking to change a bunch of stuff, you have to make sure that you have something that you're not working on to see if it inadvertently changed from all your efforts over here. And it's a way to keep us honest. Okay, Julie's got I knew I wasn't going to describe this quite right. So Julie wants to make sure we know that these 11 variables, I did say this earlier, I promise, but I'll say it again. We picked them to just learn processes. And then from there, we're expecting to see a change in all the variables. Or we're expecting you to at least know where to ask if you don't understand a variable or if there's confusion about a variable. And Kimberly, great point. 100% you will have those clear definitions. And part of the quality improvement project is for us to share the definitions and for you to say that, okay, nice try at clarity, not clear, right? Because that's another place where we think we know what we're saying, and then you can tell us it's being interpreted differently. Next slide. Okay. So the real deep dive here on the initiative analysis measures, we're going to look at percent agreement between these chart reviews done by magical medical students or otherwise, and what comes in the birth certificate. And we're going to look at that by the variable, the month, and the hospital. So it's just a nice, simple design. And then we want to see that from that baseline, there was a percent change. Oh, it is a medical student. Yay, Lindsay. Okay. That we're able to go from somewhere to somewhere, hopefully up, but not up if we're looking at the percent discrepant. So we'd like to see a positive change. And then after that, we need to measure whether the baseline to the maintenance is also working for the reasons previously stated. And then we can also look at what happened at the height of the post-intervention should be great because we focused and worked. And then it hopefully will be the same as the maintenance, but if there's a drop, we need to know that too. Or maybe it's not a drop, it's the other way. Go ahead. Next slide. So what do we need from you all? We need for you to look at this list of 11 indicators and identify and work on something about their collection that you want to improve. And we need you to identify your own process to look at those. And then we need you on these calls for the shared learning and to understand where we're going to learn from each other. Next slide. And then what are you going to get out of this? A fleece vest that says birth certificate quality project. Oh no, darn. That wasn't in the budget. You are going to get you're going to get training materials and tools that you can put into your system for new hires and for refreshers and for the ongoing understanding of the importance. You're going to have this whole big team, probably more than you ever wanted, for office hours, for emails, for consultations. We'll come to your hospital. We'll do anything you need. And then you're going to have improved accuracy and precision, and you're going to feel good about how you're contributing to population health understanding and improvements. And then you're also going to start to see how your teams can come together, which is not on this slide, but it is a very it will feel more connected. We hope that it's not an isolating journey to be a health information manager or someone entering birth data. Next slide. So here's our intention. Is this me, Julie, or do you want to do this one? I guess I'll keep rolling for time. Our intention is to have a call in September about partnering and the work that we're already promoting or asking to do around forming the team between HIM and clinical work. That's the September call. In October, we're going to look at the tools and we're going to steal from some of you, and we're going to use some best practice here on how to improve your accuracy. And then in November, we're going to identify and spread other best practice of data collection. So I'm curious, next slide, if we have 5 minutes here for, so a couple things. We can open this up now to questions for a few minutes. At the same time, we really want you to fill out that evaluation, which is a competing priority. And if you want to put stuff in the chat, we're good with that too. How is this all landing with you all on this beautiful, sort of beautiful June day? Well, some of us that have been around a long time are so grateful. Well, we're all grateful, but those that have been around, oh, not able to scan the code. Okay, so in lieu of the code, we're putting the link in the chat, good old fashioned link. So this feels, there's a little bit of excited energy among some of us because it's been so long overdue. So thank you for entering into the space with us. And it is going to save you time in the long run because there's a lot of coming back around, editing, I guess, or Cindy and Peggy would tell me it's a different word. But the real time trying to get the data right is a lot of work for you all. So by changing our system and our process and our flow, we're hopeful. Okay, great feedback here. So Marissa's saying thanks, which we appreciate. Monica wonders, should we have another check-in sooner than September? Seems like it might fall off the priority list where there's such a large gap. Okay, I love that feedback. So our thinking, and we can bring that back to the team, was we got to get all this baseline data in. And that's sort of a July and August situation. But maybe we should set up an office hours, guys, this summer, just let that self-select. We don't want teams to feel like they have to dig in yet till we sort of know the baseline, but we like that feedback. It's kind of a hopeful bit of feedback. Yeah, Kate's asking a good question, Julie, about an assignment between now and September.
Yeah, actually our goal was that we took all of the posted information with the data entry process. We've changed that into a one-page PowerPoint flowchart, and our goal was to share that with each team. So you see kind of the first thing to know is how you're for the team to know how your data is collected at your hospital, and see where those bottlenecks may be. So that was one of the assignment, and the other assignment is, yeah, our original thought was that it's always good for a team to see baseline data prior to starting. And as Brina mentioned, we have 2 hospitals who have completed data so far that we can share those hospitals, but the other ones we're not quite there yet. But do folks have other suggestion? Oh, you're unmuted, Brita.
Always so funny when that happens. It's such a great question, Kate, because our intention today was to say, bring anybody on, sort of hear the big milieu in which we're about to enter. And then what we're seeking is this teaming. Who's your clinical lead? Who's your data health information manager? And then we really want those 2 people to sort of wonder about who the team's going to be or who should be the team. And then, but I think we'll communicate soon by email, sort of some pre-work you can be doing in that teaming space. But I do think you need the baseline data in your hand to sort of to see the discrepancies, because each hospital is going to have different indicators that are off between what's actually happening in the chart. And, I'm not claiming that the chart is always accurate, but it has a little bit more opportunity for accuracy maybe than this data collection that goes on for vital record birth certificate. So once you see that you're good on 4 of them, but 7 are off, then you'll know better what the what is. But that doesn't mean you couldn't start thinking about who the team is and how you want to understand the current process. It's because I used to joke at Porter that the birth person was like in the attic. I don't know if that's still true, but so even just knowing where the attic is. Okay, so that's good, because finding the attic and wondering what goes on in the attic is sort of the summer work. But that I like the end of this call because the clarity that just came in, that just maybe a little bit of it's that like in high school they used to make you read a book over the summer before school started. So we'll give you some assignments by email, sort of that mission if you choose to accept it piece, with the recognition that we're not going to ask you to do too much before you have your data. Does that sound right, Julie? Katie?
Yes.
Okay. 12:59 team. Boy, we're so glad you came on. And now you've seen our faces and you know that we're here for you. And we'd like to hear from you frequently, because we've never done this before either. We've done a lot of other QI, but get those learning sessions on your calendar. But we'll talk to you before the fall. Last words, Julie, Katie, Peggy, Cindy.
Thank you everyone for being here and taking the time.
Thank you so much. See you soon.